We all have been dealing with a lot since the pandemic has started. Indian healthcare workers are trying their best to control the situation. National Institute of Disaster Management encourages you to take the preventive measures against the coronavirus. Always wear a mask and sanitize your hands frequently. Also follow all the protocols of social distancing. Get yourself vaccinated from your nearest vaccination center. Until then, stay home and stay safe.
So, good afternoon and welcome to the webinar on managing viruses like COVID-19, jointly organized by National Institute of Disaster Management under Ministry of Home Affairs, New Delhi, and Innovatio Curious, Foundation of Healthcare and Excellence. Firstly, I would like to welcome our Executive Director of NIDM, Major General Manoj Kumar Bindal, to this webinar. I would also like to welcome our esteemed speakers of the session. Today we have with us Sergeant R. Admiral V.K. Singh, Managing Director of Innovatio Curious, Chairman, ICFHE. We also have with us Air Marshal Dr. Pawan Kumar, Vice Chairman, RUS Education, Vice Chancellor, Lincoln American University, Guyana. We have with us Chawla, Scientist, INMAS, DRDO, and Nimisha Singh, Health Data Specialist, Communicable Disease Service, New Jersey, Department of Health, United States of America. I would like to welcome all our esteemed speakers for the session, and I would also like to welcome all the delegates, professionals, academicians, faculties, students from multidisciplinary background who have joined with us for this webinar session. I welcome you all. Moving ahead with the session, our Executive Director of NIDM was supposed to give the inaugural address, but due to work obligation, he's unable to join with us. So moving ahead with the session, I will be stating few objectives of the webinar. The devastating effects caused by enormous spread of certain kind of living organism that may spread disease, virus, or infection of plant or animal, or insect life, or an epidemic or pandemic level can be defined as biological disasters. A few of the objective of our webinar is to sensitize the participants with of biological disaster, to orient the participant with hospital perspective of biological disaster, or to discuss the innovations related within biological disaster, and to highlight the public health issues at international level. Moving ahead with the session, we have with us Dr. V.K. Singh. Sergeant Admiral V.K. Singh is Managing Director of Innovatio Curious, Chairman Innovatio Curious Foundation of Healthcare Excellence. Sir has served as Deputy Chief Medical Officer of United Nations and has visited around 42 countries. He was also the consultant of National Disaster Management Authority and has formulated national guidelines for disasters on mass destruction and casualty. He has also authored books such as Innovation in Healthcare Management, Cost-Effective and Sustainable Solution, and Planning and Designing Healthcare Facilities. We are honored to have you in our webinar, sir, as a speaker. Over to you, sir. Yes, sir. Yes, sir.
Okay, fine. Thank you. I welcome all the fellow as well as all the participants who have joined for today. And then the who are also expert in that, like Air Marshal Pawan Kapoor, would be talking about the how like COVID-19 in the hospital setting. The Dr. Raman Chawla, who was also with me in NDMA, he's a scientist of DRDO, a lot of innovation in the COVID-19. and he's now heading the Muzaffarpur, Bihar COVID hospital, and he will tell what innovations have been done and can be taken. The other way, the young lady who is in New Jersey hospital department into the handling with the COVID in the health department and Ministry of Health in New Jersey. Well, as already said so, I wanted to just mention to you that let us talk about the biological disaster. I will try to be very general in nature, and I will also like to see, don't really go into the topic which others are taking on. I remember, if you really remember, I mean, if you have read somewhere that there is 1918 and 1919, there was the Spanish flu which came up, and it was also of something like this. 500 million, that time 1/3 of the population, total population at that time was 1,500 million of the world, 500 million were affected, and 50 million had died. COVID-19, today the figure is 46.6 million, and death is 1.2 million. The US has stopped into it, and the India is the second, Brazil is the third one. Now there are many issues which people are debating that after 100 years, this particular pandemic almost of similar type has happened. That time also, the deaths were so much. Of course, now we are slightly more educated, but then also there was no vaccine. And now also there is no vaccine, which is likely to come probably in future. Last couple of months, it is going to be there for next 2 months. And now people are saying it can only happen in community. And people have talked about this is the one which has come probably by pollution or climatic changes. Climatic changes is definitely the one which has affected the many diseases. Now, let me just open up my presentation and then I can discuss with you on those presentations. You will change on? Yeah, okay, fine. I'll keep saying next and you keep changing it if I can't. Or you tell me how where to. I tried, I could not.
Yes, sir, not an issue, sir.
So you can keep telling her next and we can just keep moving the slides according to your speech, sir.
Okay, go next. Yeah. I just wanted to mention to you in the previous slide, there was nothing except that I'm not going into the classification of the disaster. Disasters are generally classified by various people. There are mainly there are two types: man-made disaster or natural disaster. And let's talk about this particular COVID-19. There are a lot of discussion. Was it a man-made into the China, or was it a mutated genes which are there of the virus created the havoc? The fact remains that the disasters of, we can say this is something which is a mixed one. It is either the natural or the, yet people have to firm up the opinion that how they will take. India had entirely a different story before 2005. I had handled a Bhuj earthquake when I was in army. And that time Ministry of Agriculture was handling all the disaster because the population was in the agriculture rural area. Subsequently, it came to the health ministry and it was very ad hoc way of handling it. And it was decided at that time, I have come to a conclusion that this particular disaster, how all the disasters should be handled. Back again, I was in Navy heading in Bombay, Navy Medical Service. And at that time, tsunami came. And then the Prime Minister, Shri Manmohan Singh ji said, this is not the way, let's handle the disaster in a better way. And then I was contacted. At that time, I said, we have already worked everything. The file somewhere is lying, and some bureaucrat has pulled it out, and then realized that everything has been worked out, but it is as usual. We are waiting for another disaster to happen to implement it. So verbatim, all that, whatever happened, a Disaster Management Act was created, was made in 2005. Gujarat already had this particular type of act, and it was that was the basis of that on which a national act was made. This is because the Gujarat had a Bhuj earthquake, and that is the reason why the Gujarat was much ahead in handling the disaster. The salient feature of that was that National Disaster Management Authority, which has been this is the after the act which has been made, it has been invoked. It gives in everything that state disasters, district disaster authority, and also create 8 battalions of National Disaster Response Force who will be ready-made, and 4 of them will be to take nuclear, biological, and chemical disaster. Those who are interested, this is already open source, and you can read it. It's very comprehensive and very nicely done, and it's clearly written how each ministry is going to play a part in the disasters. Next, please. We would also like, I would also tell you, this is one is, look back today, we are now talking at this moment. There are lots of issues which have been discussed on TV. So the knowledge has been provided to make people aware that what is a disaster and what is a biological disaster and how should we do it. No less than Prime Minister social distancing, take the mask, and how to you lock down and ultimately family members. Then take out that we have fixed attitude. And now if you really see fixed attitude, that quite a few you see on TV, Bihar election happened without any mask, social distancing. Or somebody on TV was saying, it doesn't affect Biharis, we have a lot of strong immunity. This is what is the attitude. And a lot of people are saying on the TV from the Bihar election time that this is all created and a hoax. What we are doing now is changing the individual behavior of the people who can change a group behavior. Changing behavior for any calamity, very important but most difficult thing. Some people say that can happen, it has just happened, it will happen, and it is not in our hand. Remember that in the Spanish flu 100 years back, 50 people, at least we are much less this time, and we could delay recovery rate, and this is the one which should. So repeated what it should be. Next, please. Next. Now you would find that the disaster has some factor which influence health hazard. I'm talking of, I'm specifically focus on the biological disaster. It is population density. You know, India has 1.3 billion population, and such a population density vis-a-vis America, if you really compare, we are much more. Lucky we are that we are lesser than US, which population is not as much as India. We had handled it because we have listened to the Prime Minister and we have also listened to the scientists and academicians and try to follow something. Population displacement, you have seen on the TP, was a miserable things happened. Migration took place, and there was a total existing facility, and the climate is one other one which people have said also can increase, decrease, this kind. People say winter will have another wave and the virus can thrive better. Somebody said in summer the virus can thrive less than in the winter. There's inadequacy of the food and nutrition, jobs have been lost. All this leads to other aspect of disaster. Next, please. There has been qualitative shift in India, the strategy. After 2005, when Act came up, I joined National Disaster Authority as a consultant. Dr. Raman Chawla was also with me, who is one of the speakers. The general, when you go to a couple of places which I went as a part of the NDMA, people are interested in disaster as a God's gift, more photo operations, and there was also lots of mismanagement of the essential supplies which are coming were diverted in the wrong hand. The Prime Minister said, let's shift. We should all prepare for the disaster. And third one, good if we can prevent. We can't prevent everything, we do understand, but quite a few things can be prevented. There can always be embankment on the river side to prevent since ages, the same flood and other things are happening in Bombay, in Kosi River, etc. Then something can be done. But we are all more interested that some disaster happen and we handle it and we take the cake. Well, if we take this approach, preparedness, mitigation, and in our back of mind always, and that is what we must spend time when there is no such a disaster, that would be the best. And that is what is strategy during that time of 2005 on was adopted by the government of India. Next, please. Now it is of advancement in science and technology. You have better inputs and you have better warning system. There's a decline in casualties. It is also the government has have a hazard mapping. They have got better R&D, standardization, enlargement and reinforcement of disaster prevention system, equipment and facility. All that has helped in changing the strategy, and that is how even NDMA Act, where NDRF is there. NDRF, mind you, only comes to handle the disaster. It doesn't come in the of that the state or the district or a flood prone area, etc. It is the organizations and the government and ministries have to do it. They only come when the disaster struck to see that minimum damage is done and help in recovery, and maybe at a later part government takes on to rehabilitation, because rehabilitation takes long time. It may be year plus. That is what has happened in Andaman Nicobar, in tsunami, etc. Next, please. Now, the biological disaster, generally we are concerned about epidemic. A biological disaster also can be taken, epidemic of any kind. Generally, earlier epidemics were more bacterial in origin. Now there is a slightly shift, it is more in a viral in nature. The second one is biological warfare, which is as per Geneva Convention, we are it is that we are not supposed to, but in Second World War it was used. And people are also having a stray comment that was this particular thing which leaked out, COVID-19 virus, was it intentional or otherwise? I mean, I am nobody to comment because nobody has an answer to that. Also, bioterrorism, it has happened. The suitcase bomb. In fact, all the nuclear source which is there into the cancer department, in the accelerator where nuclear source is there, one can make a dirty bomb out of it. You might have heard the in Mayapur, somebody has already given NMR into the Delhi University or the chemistry department, which has a nuclear source. Should have been very old one, but it was still active and some people had nuclear bonds. So bioterrorism are the people who understand this and take advantage. Next, please. So we'll concentrate anyway for epidemics. Biological agent, if you really see, the bacteria can be anthrax. Plague was earlier, in Surat it has happened. So it was cholera was another one. So epidemics have come, and generally initial ones, of course, the Spanish flu was the one, 1918, 1919 was a viral one. Now viruses which has created epidemics as smallpox, the hemorrhagic fever, now COVID-19, rickettsia. Don't worry about that because everybody is not a medical person. And but it's just to classify that these are the all kinds of agent which can cause epidemic. Rickettsia, fungus, toxin. Now this can happen because of lab accident, like COVID-19. It is in the nature. It is a mutation. And that is what like the new mutate 80% people if they recognize, this will take care of. Spanish flu, you have stray cases of flu now and not as epidemic incident. Next. Next, yeah. Now, if you really, this is just for, academic interest. Point have been is one of the things which has a lot of advantage. 1 gram of if 1 square kilometer you want to use various method, like conventional weapon like a guns, etc., you spend $2,000. For nuclear weapon using you when you want to kill people, dollars. And biological warfare is the poor man's atom bomb. Why I'm Ministry of Health for bioterror. So is there that they are also visualizing some threat can happen? But full-fledged war, of course, you are not going to handle. But probably epidemic, we are already handling it. But But terrorism is also we are handling it, not terrorism of biological agent, through biological agent. What is it that going to, one of the things can happen is a big question mark. Yes, next please. So Ministry of Health. Yeah, virus should be able to cause death or disease in human, animals, or plant. It's just a definition to give. Nothing. What is that we should be aware? What can be done? We have to, for any biological disaster, they have to be proper. So at any given time, at any given geographical location, suddenly there's part of cases, and that can lead into the epidemic. You might have seen Japanese encephalitis. A couple of medical colleges like Gorakhpur and other places, there have been children who have deaths. So you have to surveillance that. Can you stop it at appropriate moment before it goes full-fledged epidemic? More, and this is a very important that a clinician have to know what are the symptoms, what are the signs. In most of the cases, unfortunately, in most of, not all, they like plague, you have a treatment. Somebody started with a chloroquine, and no less than the president of US claimed posted in Northeast or one. So there's no treatment, there's no vaccine. What is there is the prevention, typically what it is, all that. And we have to investigate that is it the virus or particular disease which has come, or it is the number of such cases happen, it is one of the epidemic. And for that, what we require in an early laboratory diagnosis and a good communication. Next, please. Now, the issue at large is the communication is one which is slightly now better because of internet and other telephone, which was not there earlier. And also the laboratory network has increased. I'm not going to detail 1, 2, 3, 4. This is a classification where highly the virus can be tested. If we have few biosafety, 4, we may say 1 or low, and this is where the people who diagnose such cases in biosafety 3, they wash their, they change their clothes, they wash themselves totally, and it's totally sealed unit where they do the. They go out, discard those clothes, etc., and then go out. And nothing is allowed to go in, and vice versa. So this is what was this leak, something like this. So there has to be a rapid reaction team, and there's also, we have to stockpile the drug if there is any, or we have to keep the vaccine ready. There's no vaccine, as you know. Next, please. So what is really important is the general practitioner, local health authority has to understand that is it must be reported immediately, and it must be taken a quick approach so that it does not really go beyond your hand. Good communication and electronic network, which is now, has really helped. Now the system what has been developed at this time so far has been much, much better, because we have the system in place now. NDMA Act has been invoked, and ultimately most of the things of has been put in place, and we are better equipped and better reactions, so that people are taking care of, the medical people are taken care of, who will take care of the patients. Next. So the personal protection, all you, because every now and then we talk require the frequent has to be taken, an ordinary mask, the protective clothing. I have used it during the training part, and you really very difficult to work in this. You sweat a lot, and it is very difficult. Now lots of innovative methods have come, so that's slightly comfortable for people to work. Otherwise, if you really take the protection clothing, it is something which is very, very difficult. Collectively, what can be done is you can have shelters and tent. Like I have seen one near the airport. DRDO has created a COVID hospital which is totally in the tent. We are better protected now. We are better learning now. And that is what is, like Dr. Raman is in Bihar, who is handling one such hospital. Next, please. What is really required is reporting reliable data, rapid reporting, and the feedback. This is from the learning point of view and a lesson learned. This has been something which is really of very important for nation, for the providers, and this will be good lesson. And that is the one we have in such a short time made and ourselves prepared. We were not having the individual protection equipment, IPE, and ultimately now we are exporting it. The reactions have been quite quick and have been much better, that so much can be done in such a short time. And that is the one, is a very good sign of where scientists, academicians, doctors, everybody could have put their best, including the manufacturers who could produce this particular matter. Next. Now, I'll just draw your attention, all these kind of a disaster, nuclear, biological, chemical, what is there? You are handling mass casualty. Mass casualty incident as per WHO is any event resulting in number of victims large enough to disrupt the normal course of emergency in healthcare services is called mass casualty event. This disrupted. The hotels have been converted into the hospitals and isolation places, the doctor living places. So normal method, the beds have been created additionally. Hospitals have come up in tents, etc. So this is definitely that it fits in the COVID-19 or biological has to be taken, and it is handling the mass casualty incident as defined by WHO. Next. Now, factor affecting disasters is inventory, geography, demographic factors, vulnerability of population, frequency of occurrence, public awareness, which we are doing now, intensity because relationship, time factors, exposure factor, type of response mechanism, all that if really these are the effects of disaster. And New learning after each disaster should be incorporated into our action plan. Next. Handling of the biological casualties, you have individual protection equipment, and you have a respirator that people have to be told how they have to be disinfected, how things are isolated, and if there's any standard procedures or pre-treatment, how decontamination of these casualties or patients can be done, or even the people who are working. Incidentally, I just wanted to mention to you, when initially people are not aware, hypochlorite solution spray is the one which decontaminates. And they were throwing this particular thing in the TV on migrant population because there were no IPE, and they were saying that cruelly these people have been really procedures of decontamination. Of course, I should have been. That is, the process of decontamination is used in biological, chemical, nuclear disasters. It is that you discard the clothes, wash the clothes, use hypochlorite, and ultimately, this is the one which is gone into practice this time also. You have to also create an SOP for eating, drinking, defecation, urination, how it is there, what will be discarded, how it can move from one person to another, the food, how it should be make palatable, clean and cooked, etc. So this is all by itself is enough is now coming as editorial and WhatsApp group and TV. Of course, unfortunately, there is also some fake news or unscientific news, every kind of a thing which has been really prescribed to eat to increase the immunity, and lots of business is thriving because somebody has said it on that, and all kinds of things people are saying. There's even also toxicity developing. Somebody is using haldi ka doodh and etc. etc. Everything what is scientifically proven should be taken in moderation, and not on self-treatment of various kinds. Next, please. Yeah, next. Yeah, this is, you might have seen now in the TV or on the kit of now. This is used to be what armed forces has used it into the, but now much simplified and better equipment have come. Maybe the Dr. Raman will throw a light on it, and it is being manufactured, not only manufactured, being even exported. So is the ventilators, where I used to hear there's no ventilator, the patient cannot be taken and he needs a ventilator. Now we have so many of such ventilators. Innovative methods have been used to create such ventilator to helping the COVID patient, because breathlessness is one of the important aspects reaching into fatality. Next, please. This is a decontamination, how it is used. Person after protection, also a hypochlorite wash, or if there's nothing, large amount of water can also do that. And that is how decontamination of such biological casualties can be taken place. Of course, there are lots of things which have changed and changed for the better, and it is for the providers, they still have some problems because they have to work in such a type of environment for many hours in the hospital. Next. Yeah, there's nothing. These are my two slides in the last one. A basic rule: be aware, be alert, be alive, learn good safety and emergency management habits from the beginning. practice these habits regularly, like Israel regularly national level does such a disaster drill. Accreditation, hospital demands accreditation drill, or the disaster manual. These are at the national level, we are not. When I was part of NIDM, we created a mock drills. We did the real drills. In whole Bangalore city or Gurgaon city, it was created. Such mock drills were done, and that brings you more into the reality and learning phase. So it is important. It is not that much only medical, but it is also logistic issue. Next, please. Yeah, thank you very much for your time, and I could give you the very overview, and the specifics the other expert will do. Anything I can do, these are my contact address, and we do something, I can be contacted. Thank you very much.
Thank you. Thank you, sir. Thank you for providing a very insightful presentation and giving us an overview of biological disasters. Moving ahead with the session, the next speaker is Air Marshal Dr. Pawan Kapoor, Vice Chancellor, Russ Education, Vice Chancellor of Lincoln American University, Guyana. Sir, Dr. Pawan Kapoor is an alumnus of Armed Forces Medical College and was commissioned into Army Medical Corps on 10th October 1979. Air Marshal Pawan Kapoor has held numerous administrative and professional appointments during his career, spanning around 38 years of service in armed forces. He has served for more than a decade as Director Finance of Academy of Hospital Administration, of which he is an honorary fellow. He has also published more than 40 papers in various journals and contributed more than 10 chapters in published books on varied topics. We welcome you to our webinar, sir. Over to you.
Okay, good evening, everyone, and welcome to this program on various aspects of biological disasters. At the outset, I think I must compliment the National Institute of Disaster Management as well as University of Tourists for taking this initiative for creating awareness and giving education to the public at large. So I compliment them and I thank them for giving me this opportunity to share my experiences and to share something about hospital perspectives during biological disasters. Excuse me. Yeah. Now, needless to say, I was preceded by my teacher who taught me disaster when I was a young officer in the Indian Army. That time, Sergeant Rear Admiral V.K. Singh was in the Army as a colonel. And from there, I started my journey in learning how to manage disasters. And after being a part of the armed forces and having seen a lot of disasters and being a part of the task force in the armed forces when Ebola virus pandemic broke out in the African region, and we had a lot of troops there to prevent our troops from carrying that infection to India. I was one of the portions of the task force, and we tried to prevent that, and we were largely successful in preventing that, Ebola reaching the shores of India. Having said that, I'll be quick, crisp, and brief, and to the point, because I think Sergeant Rear Admiral V.K. Singh sir has covered almost extensively all the entire spectrum of disaster management of biological disasters. Needless to say, the biological disaster is a slightly unique. Why it is unique? Does not carry the same imperatives as are carried by the other natural disasters like earthquake, where all can go in for one, because the healthcare workers can actually attend to such disasters, knowing that they have to take care of the casualties. They can go beyond their capacity to work. But during biological disasters, somewhere they also have to take a lot of preventive measures, which can be a source of stress to them. They're also apprehensive that they can carry the infection back home to their families. So there are a lot of interplay of factors. The triaging systems are different. The management systems become different. And a lot of interactions have to take place and a lot of coordination required between the hospitals and other healthcare centers and other public health authorities. It is slightly more unique than that. Biological disaster has considerable impact on human lives. It has also impact on creating disabilities. Maybe post-infection you can have disabilities and people can become victims of the post-infection episodes. Then you have issues about isolation, quarantines, various treatment protocols that can keep changing over a period of time, because if we don't understand the agent of the concerned biological disaster, then the protocols will keep changing from time to time. There will be confusion, and it takes some more time to come to a consensus decision. So that is why a biological disaster may have a bit more impact than what other disasters can have, simply because of the uncertainty of it, in which direction are we heading. And therefore, the hospitals become a very, very important component of managing these disasters. So managing hospitals in outbreaks of infectious diseases, which could be intentional or unintentional, as it has been already brought about earlier, that could be deliberate, it could be a part of a biowarfare, it could be a part of a bioterrorism, or it could be unintentional, like a pandemic of influenza that can take place. It is complex and it requires different actions than during natural disasters, as I told you before. In such disaster, readiness to respond and appropriate action is not only a responsibility of one person, and like Surgeon General VK Singh brought about, and he spoke about it, that even general practitioners may be the first one to notice it. So therefore, it is a multifaceted operation which can start from a general practitioner and go to the public health authority and right to the national level. So therefore, we have to be very much clear as to what is expected of a hospital. So I will stick solely to the hospital perspective. I will not try to take my presentation left and right and focus only on the hospital part. You see, we have already known that the fatal pandemics of infectious diseases and possibility of using microorganisms as biological weapons are both rising worldwide. You have seen that we have been in the 21st century. We have been through various 20th century. We have been through various pandemics. Some may have come to India but not affected us that badly. Some have not come to us. As I told you earlier, Ebola did not reach us, but Ebola has taken place. We have also seen H1N1 pandemics where we were involved. We also, when we go back to Spanish flu, you saw we lost almost 50 million lives during that Spanish influenza. It was named in Spanish because it affected the entire Spanish royal family. So it was known as Spanish flu. Now coming here, if you see now, we have 48 million cases as on date across the globe in almost 10 months' time, with almost 1.2 million deaths. And we do not know when the current coronavirus pandemic is going to abate. There are waves after waves. There has been a first wave, there has been a second wave, there may be third waves. People are going back into lockdowns. So there is a lot of potential in causing a tremendous amount of death and disability and stressful situation, which can lead to a lot of emotional and physical fatigue. So therefore, hospital preparedness and response to biological disaster has a very, very active role to play in decreasing morbidity, mortality, and preventing the transmission of infections. Now let us come to what are the specific roles of any hospital in biological disaster management. We have the first and foremost is detection, followed by treatment and infection control, coordination, resource mobilization and management, training and exercises, communication and information, and system construction, planning and assessment. Now, all these roles are not an islands of excellence or can be seen in isolation themselves. All these roles are intertwined, intermingled, and they not only lead to each other, but they affect each other. I have tried to just break it up into these for the sake of ease in explaining the concept of specific role of any hospital in our biological disaster management. I will just take them one by one. When we come to detection, it is the ability to detect the infection early, because rapid detection can reduce morbidity, mortality, and prevent transmission of infection into the community. And how can you detect early? You can detect early only if you have a clinical suspicion, if you have the background knowledge of what the various types of biological infections that can take place. And when we go by the current pandemic, if this pandemic could have been detected and reported early, maybe it would not have reached the magnitude as it has reached right now. So rapid detection in the hospital is very, very important. It is based upon clinical information, your clinical knowledge and training, and it is also based upon the laboratory facilities that we have, laboratory and the other diagnostic facilities. The distinction between intentional and unintentional outbreak may be at times difficult to make out, but if it is feasible, possible, then it narrows down the spectrum of combating such disasters. But one thing is certain, delay in diagnosis with subsequent possibility of developing outbreaks of communicable diseases can be a major factor in hospital performance. So if you delay the diagnosis, then we cannot put in appropriate check mechanisms to prevent its breakout into the community. So it is very, very important to ensure that we do rapid detection and we have the facilities to do. If we do not have the facilities, we should know where those facilities are available, and there we'll come when we come to coordination, we'll come to that aspect. Rapid detection is an important factor in proper performance in biological disasters. I need not re-emphasize it, but I give an example. In the Crimean Congo fever epidemic, if diagnosis was not established on time, the disease would have spread further. Same thing in Ebola, if the diagnosis had not taken place in correctly, accurately in time, maybe this could have had more disaster impact than what the current pandemic is having. The next part is treatment and infection control. We teach triage, and everybody said triage means sorting out of casualties based upon the need of medical care they require. That is triage. But in biological disasters, the biological triage which is of importance, and I will come to that triage a bit separately in greater details because this is a new concept and a new terminology that I am introducing here. Because this biological triage is exceedingly important in the case of not only treatment, but also important for infection control. It has already been brought out earlier, the decontamination of the victim and also the decontamination of the surfaces, the decontamination of the environment. All these are important factors in the hospital premises to prevent the spread of the infection and to control the infection within a designated area. Next is the drug therapy. If it is known, it is very easy for anthrax, for plague, the drug therapy is known. So if you diagnose it early, you can prevent its spread. Same thing applies for rickettsial fevers. But for viral infections, it is not very clear. So you start using drugs, as has been the case in the current pandemic. We have been using drug therapy for prevention. We have been using drug therapy for trying to reduce the mortality and decrease the morbidity associated with this infection. You all know the drugs. We started with Tamiflu, then we started with, our remdesivir now, and we are having ivermectin, doxycycline, azithromycin, name the drug, and plus we also experimented with hydroxychloroquine as a potential preventive agent for prophylaxis. So if you have specific drug therapy, it is wonderful. If you do not have, it will be on trial and error basis that you will decide what should be the protocol. So you will have to build up the protocols. This is where the hospital comes into play, because their experiences over the short term will be able to tell us what is the correct protocol for treatment of the current situation. In COVID-19, you have seen earlier we were not using steroids. Now steroids have become a mainstay. Then we started with plasma therapy. In some cases it effective, in some cases it has not been effective. So these treatment protocols will also come. If they are available, it is very good. If the disease is known and the protocols against the disease are available, it is very easy to implement. But if they are not available, then the hospital becomes the center point of trying to find out by trial and error which protocol is most suitable for patient in which condition. Of course, you do need supportive therapy in terms of oxygen and other supportive therapy that is required. Where there is possibility of having pre and post exposure prophylaxis, where it is available, that can be used. Where it is not available, then you have to look for it. Like in the current pandemic, we are still searching for a vaccine, and we do not know when it is going to come and whether it is going to be safe and it's going to be efficacious. That only time will tell. But one of the most important feature of biomedical hazards and of bio disasters control is nursing care. Everything boils around nursing care, because nursing care gives the necessary supportive therapy and they are present round the clock on the bedside of the patient. So having skilled and trained nursing manpower in adequate quantity will be the hallmark of good management of biological disaster. The next part is that if you have detected something which is unusual, if you have detected something which you know is likely to be infective, then you have to follow isolation. You have to put patients in isolation. Therefore, hospitals have to prepare for isolation. This pandemic has ensured that isolation facilities are made available. Isolation facilities both in general wards, isolation facilities for aerosol generating procedures, isolation facilities for taking care of critical care patients. All these have to be a system, have to be built in, and there have to be systems which are going to be hybrid systems. Hybrid system, I mean that today you're working as a normal hospital, but tomorrow quickly you can have a negative air ventilation isolation room prepared out of this. So now the future of hospital designing should be based upon such systems that quickly you can change your heating, ventilation, and air conditioning systems, or you can introduce ventilatory systems wherein you can change your current level of operations into operations that are most suitable for the infectious agent that has been detected during the process of care. So you have to have such type of flexibility. And as we said that flexibility is the hallmark of any disaster plan, here also you have to have flexibility in taking care of patients so that not only patients are taken care of, but the chain of transmission is interrupted. Needless to say, disinfection and sterilization is the cornerstone of preventing infections. So disinfection practices, whatever agents are being used, they may be continued to be used until unless you get an disinfection agent which is specific to that organism. By and large, the current disinfection agents that our hospital is using, like 70 to 90% alcohol, like you are using 5% Lysol for disinfection of the hospital surroundings and environment, 1% sodium hypochlorite, and their contact periods, all this is known. The same things can continue to be used in case of all such biological disasters until unless the research comes out with any other disinfection agent, then that can be implemented. But otherwise, the routine disinfection protocol should be followed. The other important aspect of treatment and infection control is protection of staff. And no matter what is the infectious agent, it is bacterial, it is viral, it is fungal, no matter what. What is important is hand hygiene. I think COVID-19 has taught the hospitals what NABH in its 15 years could not teach them, that hand hygiene is the cornerstone for prevention of infection from patient to patient, from patient to doctors, and from doctors to patients, or from nurses to patients, or from healthcare workers to patients, or healthcare workers to patients. So hand hygiene has to be an inborn, inbuilt, and an integral mechanism inside the hospital biological disaster plan. Second issue has already been discussed in detail by Surgeon Rear Admiral D.P. Singh sir, the use of personal protective equipment. I will not go more into details. We already emphasized that nowadays we have to use, for example, in COVID-19 crisis, we have to use PPE. But when other infectious diseases are concerned, we should know that this personal protective equipment, which includes your headgear, your mask, your face shields, your goggles, your gloves, your overalls, your footwears, it includes all those things. they need not be used in certain biological disasters. So it is not necessarily the same type of PPEs to be used. What is important is training in the use of PPE, which PPE to be used by whom and by when, and what is the indication for use. That should be known, and that should have been built in the infection control practices of the hospital. Stress and fatigue management is another important thing. Therefore, staggering of duties, having shifts, all this become the part of protection of staff and prevents infection from passing on, because these fatigues, and if staff is fatigued, the staff fatigue can give rise to not only physical but emotional fatigue. It can also give rise to break or breach in the protocols of use of hand hygiene and personal protective equipment that can not only expose the staff to infection, but he can become a source of infection to others. Needless to say that in all this, hospital has to follow the biomedical waste management rules, and therefore hospital administration and the staff, especially the housekeeping and the supervisory staff and the nursing staff, must be well versed with the waste management protocols. And last but not the least, hospital has a very important role to play in contributing to the ongoing research and revision of protocols. I will come back to the first slide which we started in case of the treatment and infection control over the biological triage. This biological triage in case of biological hazards is different. So this triage will say who are the people who are susceptible but not exposed. So these people can be told to take preventive measures that are necessary for them to take. There are people who are exposed. They are those contacts. They are called contacts. So these exposed people, but they are not infectious. These exposed people have to be put into quarantine for the duration of incubation period of that particular infecting agent. Like we had earlier started here, that the period of quarantine will be 14 days. Infectious, those cases who are infectious, who need to be isolated from the general population, and where they have to put into a well-ventilated area. They may be cohort areas with the same people in the same place, or they may require some aerosol generating procedures. In such cases, they have to be put into negative ventilation areas. Then there are others who probably will die or who have recovered, so they can be different areas who can become sources of antibodies, like we are trying to do plasma therapy now, those who have recovered, and those who are dead, they have to undergo a proper disposal as per laid down protocols. So protocols of managing death, that is also important, and how the disposal of dead is going to take place is also going to be an ingredient part of this trial system. And of course, you could identify those who are protected by vaccination or prophylaxis. So those who are already protected by known vaccine, or they have a prophylaxis for that particular biological disaster, then that becomes those people that who are there in the population, but they need not be focused upon. All this biological triage, based upon this, the hospital can decide after doing this triage which people are to be admitted, which people may be asked not to come to the hospital for routine cases, for routine ailments, and which are the cases which can send back to the community and who can serve as agents of change and agents of change for behavior, because they suffered the disease, then they can be the sources of influencing individual behaviors in the society. These biological triage is very, very vital, not only for treatment purposes, but most vital for controlling the transmission or the spread of the transmission. So it becomes easy to control and treat the patients. It prevents loss of unnecessary resources onto people who are already protected or onto people who are susceptible. So then you have to use that those resources need not be utilized on these people. It will reduce the probability of transmission of the communicable disease, and it will decrease the burden of hospitalization by reducing the number of visits to the hospital. You see, the purpose of lockdown was what? The purpose of lockdown was that all those who are susceptible but not infected, the infection can be prevented into them. That was the purpose of lockdown. Okay, maybe it did not result in the desired effect, but it definitely delayed the speed of transmission, and who knows, it prevented a lot of morbidity and mortality. We cannot comment right now on that. The next important part in the entire scenario is coordination. And what is important is both intrasectoral coordination and intersectoral coordination. By intrasectoral coordination, I mean the coordination that occurs within the hospital. And the coordination within the hospital can best be achieved by establishing an incident command system, wherein you can have an integrated structure that will provide coordination within the hospital, which patient to be sent to isolation, which patient are to be discharged, which labs the results are to be sent, the coordination between the radiology department, the lab department, and the clinical departments, the planning of the coordinate, the planning mechanism, the operations, logistics support in terms of getting the manpower and the nurses, and controlling the entire operations. This is the role of the incident command system, which not only looks within the hospital for coordination, but it also coordinates outside the hospital in helping in providing appropriate response to the particular biological disaster. The intersectoral coordination means you have to liaise with the public health authorities for notification of the event which is important. You have to look after the referral laboratory support, which referral laboratories you are supposed to be sending the patient samples in case you do not have those facilities yourself. Then evacuation and transfer of afflicted patients to other facilities and hospitals. Provisioning of appropriate drugs. In the current scenario, you know that we had to create plasma banks. So coordination had to take place with those plasma banks to provide plasma. Similarly, for getting drugs like remdesivir, which are not only expensive, but which are not easy to come by. So all these things, they require coordination. And this coordination has to take place from within the hospital with other organizations. So this type of coordination needs a memorandum of agreement and understanding and partnership planning with other hospitals, other health centers, with National Center for Disease Control, with the government, Ministry of Health and Family Welfare, and local municipal authorities. You know, when in the armed forces, we always have an understanding with other hospitals for any type of disaster, including for arrangement of blood. Why we do it? Because once we have an agreement, that agreement can be rehearsed for implementation during the drills, and that agreement can be put into implementation once the actual event takes place. So it is important to be proactive and understand the importance of intersectoral coordination, and especially in biological disaster, where all hospitals should know what are their limitations, what is their capacity for both clinical care and diagnostic and therapeutic care. So if they have limitations, they know which hospitals they should be able to liaise with in case the need such arises. So therefore, this is also a very important part. Other thing, of course, you can have various international, coordination mechanism which will be taken care by the government in power at that point of time. Another important thing that the hospitals must be aware of is the human resource. In biological disaster, as I brought out earlier, human resources are of extreme importance because they are the skill set that we have got. They are the knowledge banks that we have got. They are the ones who are going to take care of the victims of these biological disasters. So we have, and they can also become victims of these biological disasters. This is where a biological disaster differs from earthquakes and floods. So therefore, such victims and such human resource is a very, very important asset. And we have to ensure that these human resources remain an asset to us. Today in this country, we have lost almost 500 doctors, around 1,500 nurses to COVID-19. It's a loss of a well-trained asset. And to fill up this gap, it will take another few years to get this gap filled. Therefore, human resources have to be managed properly. And this is a very important resource which has to be planned for. And therefore, you have to get in as much human resource as possible. At the same point of time, we have to ensure that this human resource remains protected. Second is physical infrastructure. So we have to plan for the surge capacity, and like Surgeon Rear Admiral Vipin Singh told you, that we have to go and think out of the box, how to create extra capacity in the structure in terms of space for decontamination, space for isolation. All this has to be culled out from the existing space. So all these plans should be in place. Same thing applies for material and medical supplies. All your consumables, your equipment, which includes your personal and protective equipment, plus your lab reagents, plus your lab equipment and your radiology equipment. Also, for all these activities, you have to have financial and budgetary allocation. So you must know that you have a contingency fund available with you for taking care of such disasters. In this way, even you must have liaison network. The hospital is required to establish a liaison network with the government of India so that such funds can be released to them for managing these biological disasters. Again, in the armed forces, we have a saying, the more you sweat in peace, the less you bleed in war. Sweat in peace means training. We also have a saying in the armed forces medical services, if you are at war during peace, you are at peace during war. That means if you take your hospital exercises, if you take your training seriously and don't take it as a mundane daily routine affair, to take all this seriously, when the epidemic or the pandemic strikes, the hospital will not panic. The hospital management will not panic. And therefore, education and training is a very, very important component in the from the hospital's point of view. And therefore, hospital has to ensure that it does its mock exercises diligently. There can be some desktop exercises, there can be some mock drills. And then they must assess and evaluate these exercises and mock drills to learn from them that what is the next educational content they should give out to their own staff so that they remain updated with whatever knowledge that they have acquired. So this training has to be up to date and periodic. Now, this is already discussed in details by Secretary Vipin Singh, but I think my presentation will be incomplete if I do not talk about risk communication. This is one of the central components in any hospital which has prepared itself for managing biological disasters. Because when an outbreak, whenever an outbreak occurs and general public health is compromised, because that is what happens, general public health gets compromised, then direct interventions and treatment options, they may be limited due to the lack of time and due to need of resources. This is where communication, notification and guidance are often the most important tools of public health in risk management during such outbreaks and during such incidences. Communication readiness will reduce the response time to crisis, will lead to early diagnosis, will prevent spread of infection. So this is extremely important for a biological disaster, because whatever you do has a direct impact on the transmission of the disease. And what we need to do is to prevent the transmission of disease under these biological disasters. So therefore, the communication and information systems during disasters, they help you to earn the confidence of people, and they help you to earn their acceptance of certain behaviors. They help you in disease surveillance, and they help in reduction of confusion. Therefore, having a proper, appropriate communication system is extremely important both for the hospital staff as well as for the public at large. There are a lot of guidelines given this. I cannot go into details of that, but this is an important component of the hospital from the hospital point of view. Last, of course, planning. We know there is a disaster management plan. It's essential to ensure preparedness and response. There is a very nice, hospital guideline for preparedness for biological disasters. It has been brought out by the NDMA. It is available on their website. I would request all of you that today, after this session is over, please go there download. It will tell you how to plan and prepare for a biological disaster. They give you the guideline. I am only giving a summary here that planning the disaster management plan, whatever we give the guidance, nothing but you have to prepare a set of procedures, a set of policies, a set of international inter-coordination patterns. What are the roles and responsibilities? What are the contingencies that need to be developed to prepare and respond adequately, appropriately, and timely to a biological disaster? Here the planning would focus on early detection, as we said, brought out earlier, and rapid diagnostic systems, emergency response to plan to potential biological agents. Some are known. They're being classified into category A, B, and C. All that is given in these guidelines. You can go through them and they tell you exactly what are the potential biological agents and what are the treatment facilities available for each. So far, what they do not tell you is for such contingencies like COVID-19, which will probably the experience will tell us. Again, building surge capacities, as I already brought out earlier, that is resource planning and mobilization, rapid communication plans, protection of healthcare workers, potential quarantine exposure, who's to be quarantined and how, both individual and groups, staff training, disposal of the dead, management of media, developing your own checklists and ensuring that your checklists are complete, which will help you in training, and a hospital recovery plan once the pandemic or the epidemic passes away or the biological agent has been taken control of. How does the hospital recovery plan is to be implemented? So this is the planning. This should have been the first part, but I brought it to the last part, that why it is important, because I built upon that what is important is detection, what is important is early diagnosis, treatment, infection control, coordination, building of human, getting the resources together, having a good communication plan, and doing training and education. So after sharing all that, I have come to planning, because planning should include all that what we discussed prior to this. Then what is the take-home message? Hospital management in outbreaks of biological hazards, whether intentional or unintentional, is complex. Why it is complex? We discuss the factors of complexity. Premise of planning is like for any other disaster, but attributes are different. The focus is on early detection and treatment of the biological agent. It requires to be notified and needs a multi-sectoral coordinated response. There is a need to ensure that you build proper diagnostic and treatment protocols. The security and safety of the healthcare worker and his or her protection is therefore an important component. Resource mobilization and appropriate utilization of existing resources is also a very important aspect. And staff training and education is a key area. The hospital biological disaster plan needs to have an efficient system of alert and staff assignments. A unified medical command, like I told you, incident command system should be there, and a system of mobilization of resources, that is medical, nursing, lab, radiology, and all other resources, and administrative staff, mobilization of a medical store supply and equipment, conversion of usable space into clearly defined areas for reception, decontamination, triage, observation, and immediate care, and isolation facilities. Procedure for prompt transfer of patients within hospitals, procedure for discharge, referral, transfer of patients, including transportation, where all your agreements will come into place, mock exercises and lessons learned, and revisiting those lessons to improve upon your plan. Because during such disasters, failure to plan is planning to fail. Planning provides the opportunity to network and engage participants prior to the event. Planning provides the opportunity to resolve issues outside of the heat of the battle. So thank you very much for your patience and perseverance and for hearing me out. I shared something from my experiences and something what is there in various texts, and exactly what I have prepared for you is based upon the NDMA guidelines, but slightly presented in a different fashion. I would still request you that please go back to the website, download this document, and go through this medical preparedness of hospitals during biological disasters. It's a very well prepared document. I give full credit to all of them, and I know Surgeon Rear Admiral D.K. Singh was very closely associated with the preparation of this document. So thank you, sir, and thank you, NIDM, for this opportunity. I want to tell all of you that at the time of biological disaster, there is no time for planning. That is the time for implementing the plan. That is the time for doing. Thank you very much. And Jai Hind.
Thank you. Thank you, sir, for a very insightful and very in-depth presentation on hospital perspective of biological disaster. Moving ahead with the session, we have with us Dr. Raman Chawla, scientist INMAS DRDO. Dr. Chawla completed his 15 years of research and development experience in multidisciplinary field, ranging from drug development, disaster management to CBRN mitigation. To his credit, he has 12 CBRN books, manuals related to CBRN mitigation, 120 publication, chapters in journal, books of international repute. Dr. Chawla has also 4 patents of formulation of treatment regime in CBRN patents attack. And recently, in fight against COVID, he and his team members have developed CBRN Ultra Devices disinfection ecosystem for health and non-health care infrastructure. We welcome you to our webinar, sir. Over to you.
So, first of all, I would like to thank you, Dr. V.K. Singh, who has actually invited me for this. He is, my previous speaker has already told that he was colonel when he was a mentor for him, but when he left army and retired and joined NDMA, he was mentor for me. So with his guidance, we have developed National Disaster Management Guidelines on medical preparedness, chemical, biological, radiological, nuclear. At all that time from 2006 till 2008, I was guided by him. Prior to that, I was working with Institute of Nuclear Medicine and Allied Sciences as research fellow. Now I'm a scientist there. This institute I just tell you about, this is called Institute of Nuclear Medicine and Allied Sciences. This is one of the Life Sciences Institute of Defense Research and Development Organization, stationed at the New Delhi and near Timarpur, North University, near to National Center for Disease Control. And this is basically one of the DRDO's leading institution in medical management of CBR and emergencies. So we are already, our department called Division of CBR and Defense basically works only for CBR and defense activities. And we are working on all the drills, exercises, innovative solutions. So when prior to pandemic even started, we are working on the different protective clothing, which can be multi-used, and lots of different types of masks. And that we are working on from last few years, which was used during this emergency also. And after the pandemic has started, we started working on a disinfection ecosystem with respect to the environmental perspective. As my topic is innovations for biological disasters, so I am just working. This work which I am showing is from April till date, and me and my team of scientists and other fellows worked day and night to develop these technologies to provide solutions not for present pandemic as well as the future pandemic. So coming to some few definitions, like how H1N1 and COVID-19, because my whole lecture will be focusing only on the purpose of innovation, but prior to that, how things are different now. During H1N1, there was a 7-day cycle, and at present we ranges from 14 to 21-day cycle. So we have more persons living more time in the hospital or in the quarantine period, which causes higher economic burden, and which causes more chances, more longer lockdown period. And that's why this is a different situation. That H1N1 was having a higher mortality rate, but by the time COVID-19 ends, we will be able to understand whether this will be more severe or lesser severe. But with respect to number of spreadability rate, H1N1 is very less as compared to COVID-19 on some part. Severity wise, so when we compare two different viruses, two different bacteria, or any spread during pandemic prior to what happens in the past. So while H1N1 we have some antivirals which are working to some people. So we have some solutions. So the all across the boards, the panic was less. But when we come to COVID-19, since there was no drug vaccine at present, even not that, So whatever that we are doing for symptomatic and supportive care, the panic was more. So when the experiences we are seeing in the western part of the world prior to reaching it to here, the spread out rate. So doing a lockdown is the only the wise decision at that time to actually, as my previous speaker has told, to delay the process, to prepare ourselves. A country of 130 crore people needs preparation to actually go into the pandemic resistance, to develop pandemic resistance. On the other hand, if you see Ebola, that's not reached, but in 2013, approximately 28,000 people got affected all across the world and 11,000 died. At that time itself, it touches our door, and as Sir has already told me, they are able to prevent it coming into the country. Recently, prior to this pandemic, Nipah started in one of our states, but we are able to control it. So it is actually the time by which it starts at origin. If it is biological disaster, if it is controlled at the start of origin, at the right time, at the right force, and the right ecosystem, and thus dedicated to just control it, putting all control measures, and also creating awareness to the other part of the world, creating other awareness to the, if it is spreading out, then they are spreading word prior to the spread. Then every pandemic in the future is controlled. But this time this hasn't happened. Now comes news versus old. There is a new COVID versus the old SARS, which has occurred in 2003. So there's a difference between the two viruses, lots of differences. Now the spreadability is so fast that it jumps very fast. It actually needs to survive. Virus spreads or bacteria spreads or microbes spreads. They do not want to kill us. They just want to spread. But in during their jumps, because of a lesser immunity, you might die. So, and some are designed to kill, which are biological warfare agents, which might not jump at a faster rate, but kills instantly. So nature has both type of this. First, nature subsides everything which comes on its own, goes on its own. But by that time, the whole ecosystem differs. As the New World Order said, in the New World Order, pandemic has unleashed the poor man's atom bomb. A poor man's atom bomb, known earlier as, if you see the terminologies in the World War II, was NBC. B was in the middle. Then it comes CBRN. Still B is in the middle. Why B is always in the middle from centuries? Because B has a potential to come to the first, but not being used because the country, the source, the systems which uses it might get affected eventually in time. So that's why it was always in the B. But now, even after COVID-19, the amount of impact which we are seeing in the globe level, it is now understood by more of our state-sponsored terrorists also. So the worry is that in the future, COVID-19 will be controlled, will be mitigated, and we will be living in a world in which the people are more aware to prevent themselves from the pandemic, and the state-sponsored terrorists are more aware to use such type of agents or different types. So that's the worry for the future. Now comes, there is a word called decontamination and there is a word called disinfection. We irreversibly uses both words together. I just want to clarify on that part that whenever the biological disasters we talk about, we always talk about disinfection. But the material or area which we are sweeping off with chemical agents, we do decontamination. But the purpose is to actually remove the infectious material. A contamination could be a dead material, a chemical or a radiological agent, which is contaminating the surface and entering but not multiplying. But infectious agent is multiplying. So disinfection agent, if it is lying on the surface, so we need to remove it, or that's called decontamination or disinfection, similar point. But when it is entering into our body, then only it is causing infection. So disinfecting a human body for a purpose is not for doing any purpose. So decontaminating a human person doing a purpose to lower the burden of contaminant. But decontaminating an infected person will not serve the actual purpose. So the only part is that they need to be remove their clothes and clean it, sanitize themselves, and to go into the systems. But infectious inside, so they can infect easily anybody. Then comes a new terminology, protection
Dr.
versus
Raman, I'm so sorry to interrupt you. Can you put your slide on presentation mode?
Okay.
Yeah, and also, sir, because of in the interest of the time, we'll keep the session a little short than planned. So
Okay.
instead of 20, we request you to wind up in 15 minutes if that's possible, sir.
Okay.
Thank you.
So by the time it goes to the iCloud, then I will continue my points.
Yes, sir, please.
So protection versus multi-use protection. Protection refers to when you are using a disposable PPEs or disposable gloves and this. But when the country like 130 crore, and you need a lots of continuous requirement of the resources, then we need to use multi-use protection. So we have developed one technology called as Protecton, which is a multi-use protective clothing, which can be used 30 times after with the laundry wash. So after protection versus multi-use protection. So multi-use protections are the clothing which can be used for 30 days or 30 times with a laundry wash, which is a standard called NFPA 1999-2018 standard, a global standard. So we have complied and we made this product also. The last point is social disruption, and we are in the social disruption mode right now, and we need to develop resistance ecosystems. So resistant ecosystem means when you are working with for an organization, you need to understand that the entry itself should have some preventive measure. Their essential staff should have personalized protection. They should have working space sanitization, area disinfection, safe patient transfer, hand sanitization. New is alcohol free, touching surfaces. New is something which can be sustained for a while. Isolated wards, why not to use some new advancement material? And the purpose is, or the focus of it is, the clean, sanitize, and disinfect with environment in perspective. So I'm just coming now, switching over with the direct into the technology. This is the first technology is called as Ultra Switch. It's a 7 feet Almira-based systems in which we create a ozonated environment followed by UVC environment, which completely disinfect any product you see and without any heat. So basically, it generates high level of ozones inside a confined chamber. As you have seen the blue light, this is after ozone, the UV is automatically switched over, and then ozone first disinfect each part of the any product which you are placing inside it, and then UVC converts ozone back to oxygen. So it is completely environmental friendly and very cost effective technology as compared to any existing disinfection systems available in the world. The second is, as I said, entry to the organizations. So we are at present using medical surgical mask, which is one use and one throw, which is increasing our waste. So we have developed in DRDO a mask called India 365 masks. This India 365 mask, as it is a box with two masks. Each mask, as you are seeing in that front, this mask has these crisscross areas, which is called static grid. So what happens is, if the virus comes, it sticks on the surface and it does not shed. So if a person without mask even current point of view, and you have just exposed to a person which is infected with the virus, it does not shed on that. Inside it, there is a complete hydrophilic layer, and it qualifies all the global standards for being used as a mask for 30 days in an isolated ward and 100 days with mild wash for all other workers which are working in disinfection and moderate and low risk areas. So it is basically India 365. So two masks comes in a one box. So it works for 200 working days. Another is Ati Swachh. It is a smaller unit of Ultra Swachh so that it can be placed at any departmental level. And there is a problem in hospitals to deal with the items which are of high value, like endoscopes, and but cannot be autoclaved, but that are used with the patient and then need to be used again, but there is no mechanism available. So we have developed this Ati Swachh heat sensitive medical device disinfection unit, also with the same principle. With it has a nozzle, ozonated generators inside it, and it's a single switch operation. So automatically after ozone, it uses UVC, and then to completely disinfect the material, and with a stickers available which converts into color once it is the disinfection procedures converted into. All made in India at Inma's DRDO only. And this has been tested with Geobacillus stereothermophilus, a gold standard bacterial spores which has been used for heat resistant. It's a heat resistant bacteria, which is a very resistant bacteria as compared to any viruses, COVID-19 even. Another product is called ORCS sanitization unit, which is called as Poon Swachh. So the problem is that what we are using it at present as a chlorine component, and at present I am sitting in the COVID hospital of Muzaffarpur. We are even using this HOCS as one. But this new system, which has recently come, is basically generated ozonated fog. And recently, Japanese researchers have proven that continuous can kill COVID virus. We have tested against bacterial spores, and we are now tested even against COVID virus also. Basically, it's generated a ozonated fog along with the solution, which is an organic solution developed to enhance the process of ozonated fog, and it spreads in a 10 by 10 by 12 of room. In 15 minutes, the complete room gets sanitized. We have tested against multiple bacterials in the surface disinfection procedures. This is the why it can be used for isolated wards, hostel rooms, office spaces, transportation vehicles. Another aspect of challenge was to transfer a person from either from home to the ambulance or from ambulance to the hospital, and then within the COVID hospital, between the departments, if they need to be going to a department where X-ray need to be done or some extra things need to be done. So we have developed this called Taran Har on that line. Taran Safe Passage Patient Transfer System, completely indigenous, one of its kind in the country. Basically, it has a suction apparatus which sucks the anything which it is exhaling. The patient is sitting inside this chamber, sucking the normal air from the outside, but whatever it is exhaling, it has been sucked backside, goes into the chamber given at the lower side, and this is containing UVC as well as HEPA filters with bactericidal enzymes, which converts that clear that air and remove the coming air out is completely clean, so that the persons who is taking him is safe. So it works in this way that you just open the main and this 4 air sucks comes in and UVC filter gets on, and then it works. It can be used at multiple sites even for CBR and evacuation. This is the smallest unit called Mino ozonizer. At presently, it is generally these things are being imported from China. So we have made it in India because we are developing as an accessory to our Ultra Swachh, but we have then now launched it separately also. Basically, it can generate 5 liter of ozonated water within 15 minutes in your house, which can be used for fruits and vegetable washes to clean up your foods. It can be used also in hotel, restaurants, sanitization clinics for like the caterers which are supporting the clinic. Every place to clean and sanitize your fruits and vegetables. This is called Trinetra hand sanitization. One of the problems which we have found out that with time, the alcohol will cause problem and chronic toxicity for the hands and others, and children should not use our alcohol-based sanitizers. So we have developed this complete unit has also again the same technology, ozonated water. It is a continuous ozonated water generator, as well as we add some Triogni solutions which enhances its capacity to a large extent. And we have tested against bacterial spores. We have tested against now COVID also. So this is basically a replacement for the alcohol-based sanitizing systems. These are the solutions which have been put into Poon Swachh, the Samagr Swachh, and the Trinetra, which I showed earlier. This is called Triogni. It's a Triogni in Sanskrit. It is called organic. It's basically the 3 different solutions, completely organic in nature, completely herbal in nature, and these have been tested against bacterial spores in presence of ozonated water as well as in absence of ozonated water, so that it can be used directly with water and also used in our previous systems. Another aspect is that we use foam in our isolated wards in every place, and the foam, if it is open, the foam is an open space. Once the contamination or the disinfection goes in, cleaning is a very, very cumbersome and a costly process. So what we have developed is a viscoelastic gel. It is a gel with a higher cushioning level with a Shore value less than 0. Now we have coated with a solution called COVID Coat, which provides them adequate protection and does not prevent any type of biofouling. That means there is no microbial growth possible on this isolated ward gel sheet. It's a complete cushioning sheet, so it has a very less disinfection cycle. It can be easily washed with even the detergents and also with any disinfection. So we don't need to use HOCLs or Sterigen or some high-end equipments for cleaning our beds, which are used in isolated ward. It can be used in home also. So it is a completely safe cushioning solutions which can be used in isolated wards, and especially the hot OTs, because the new ecosystems require such systems, which should not be, it should not increase the waste. The point is, same the COVID support solution which we have used on this can be used for prevent biofouling on all the coating surfaces. One coating prevented for any microbial growth for 90 days. It is tested and validated against COVID-19 virus also. See, these are the industries and things, now the ecosystems need to use these technologies to prevent the spread of virus by developing an ecosystem which can not only work for the COVID-19 as well as the future pandemic. As ozonated water, ozonated sinks works against entire spectra of the microorganisms and viruses. So this is the ecosystems. If we just, I'm just summarizing now. This the first thing is Protecton. So multi-use PPEs, which has a 30-day cycle, and it can be increased to a 100-day cycle when used with Ultra Swatch. So it reduces the cost as well as the biomedical waste drastically. India 365 masks do the same. Third is viscoelastic gel with COVID coat. It reduces the waste of the material as well as the use of a very high environmentally non-sensitive disinfectants to a low cost. COVID coat as such can be used for all the surface disinfections for a long term. We are using it, we are now given the presentation to Delhi Metro Rail Corporation also, so that we can coat there all the surfaces with the COVID coat. Hand sanitization unit, now it is to replace the all the alcohol base. So this system do not have any quaternarium ions, does not have any type of a toxic material. It is completely safe, even can be used from child to the eldermost person, and very, very cost effective. That means it is one wash is in 1/100th of 1 paisa, which is at present is 2 rupees per wash in alcohol cases. Similarly, the ozonated fog. This is ozonated fog basically change the complete spectrum of replacing HOCl, NOCl at multiple places. So these are the ones which can provide a low cost by the factor of 50 to 70% reduced cost of the disinfection of a room or a place or its area. Safe passage transfer system, no such item at present exists in the country, and this is a very, very important system for transferring of the material. And Ati Swatch is a ideal product for the medical heat sensitive medical device disinfection unit. So you can reach to all these products by going to the website called ultraswatch.in, and you can download all the FAQs, all the materials, everything has been loaded to this website. I'll just show you the glimpse of the website prior to closing the my session. So this is the website, and you can go for hand sanitization to room sanitization, Triogni, heat sensitive, PPE, patient, mini ozonizers. The complete details, complete videos, complete product details, complete FAQs, everything is there. So keeping the time constraint, I'll just closing my presentation, and thank you very much for giving me the opportunity to share my innovations with you. And I hope that will benefit you and benefit your organizations and ecosystems in the future. And for any other query, the numbers are there with us for us. Thank you very much.
Thank you. Thank you. Thank you, sir, for your presentation on innovations in biological disaster, which was in very detailed format. Moving ahead with the session, we have with us Nimisha Singh. Nimisha Singh is Health Data Specialist at Communicable Disease Service, New Jersey Department of Health, US. She is also editor of InnoHealth magazine. She has pursued her Masters of Public Health from Rutgers School of Public Health, New Jersey, US, and Masters in Hospital and Health Management from Indian Institute of Health Management Research, IIHMR, Jaipur, India. Over to you, ma'am, and welcome to our webinar.
So I'm here to present the topic on international public health issues in biological disaster like COVID-19. So just to give a background, the current global law for pandemic or epidemic response is the International Health Regulation, It is basically it assists 196 countries to prevent, protect, and basically, respond to various global public health crises. Uh, IHR, that is the International Health Regulation, was basically revised in 2005 after the SARS epidemic in 2003. And WHO coordinates these regulations and implement these IHR laws. So they provide guidance, training, and various tools to all the countries, to their member countries, for strengthening their capacity to detect, verify, and respond to these public health crises. Excuse me. So IHR also includes measures to avoid any unnecessary interference in international trade and travel also in such situations. WHO has the power of declaring public health excuse me, situation as an epidemic or a pandemic based on the data they receive from various countries. When COVID-19 happened, there was a lot of blame game between the countries and WHO regarding declaring, the pandemic very late. The WHO said that they did not receive the data on time. They didn't have the accurate information to make that decision. So all this really shows that we were not ready. And there's this index called the Global Health Security Index. So in that also, so this is basically a report which is compiled by John Hopkins University Nuclear Threat Institute Initiative and Economist Intelligence Unit. So they score around 195 countries on biological security and disease readiness. So even in that index, it came to notice that the world top scorer in that index, US, was also not fully ready for an pandemic. In that report, they state that none of the countries are fully prepared for a pandemic, as each country have their own kind of gaps which need to be addressed. So therefore, it is like evident that the current system is not working and needs to be improvised by creating various innovative pandemic response systems internationally, as we have seen that the impact of such biological disaster is huge on public's health and well-being. So talking about the impact, so talking about the impact, of course, we have observed shortage of food. There has been acute hunger. So in 2019, there were around 135 million people worldwide experiencing hunger, but by end of 2020, there'll be around 265 million people, having this facing hunger. Nearly half of the world population, about 3.3 billion global workforce, has or are at risk of losing their jobs. So economic issues such as rising prices, disrupted supply chain, slow revenue growth. So these are all the impacts of a biological disaster on a public's life and health. The other healthcare issues get delayed. There is overload on the hospitals. There is strain among the healthcare workers. Also, there is mental health issues due to the job loss and isolation during these situations. There is also impact on the education of children. There is restricted travel and trade restrictions. So all these issues we all are aware of as we have faced them. But these issues have really impacted the most vulnerable population, and it has widened the social inequality. So if we compare the social inequality prior to the pandemic, it has just widened up. So the public health issues are basically when we talk about such biological disasters. So we have seen that there is a lack of strong infrastructure with effective epidemiology, investigations, preparedness plans, training programs. There is no centralized or integrated surveillance system to detect the early signals of such outbreaks, to inform the healthcare workers or the public health officials of such kind of outbreak happening, so that they are prepared. Another problem is there is lack of community involvement. uh, there is information regarding what to do during any biological disaster is not available to the common people. They are not trained on to what they are not made aware of do's and don'ts. The spread of any communicable disease can be prevented by quarantine, isolation, preventions like wearing masks, social distancing. So all these, washing hands, hand hygiene is the most also one of the important things. So all these preventive measures were not communicated to people before COVID happened, but now we have seen that everyone knows these terms. Even children are being taught in school that wash your hands, maintain social distancing, wear masks. So involvement of community leaders is also an important thing which is lacking. So involvement of community leaders or religious leaders or political leaders is really important to create that awareness and communicate regarding such pandemics or epidemics, biological disasters, as a lot of people follow such leaders. So this is an important thing which should be considered and which is lacking. There is also shortage of public health experts. There is shortage of uh, nursing and all healthcare frontline workers. So if if I tell anyone that I'm doing public health and who is not aware of the health care who's not from healthcare background, so I've had this situation where people have asked me that, oh, what is your work like? Are you a doctor? Oh, then what does a public health expert do? So it is really important. But once COVID happened, now everyone knows what's the kind of work a public health expert does, and what are their roles and responsibilities. So all these people have to be trained, and in biological disasters on and its impacts, and how they can also kind of help themselves during such biological disasters. The other thing which is lacking is uh, Yeah. Another thing which is lacking is that the right information is not, it should reach to the right people at the right time, which we saw that did not happen in this case. WHO can only declare a pandemic or epidemic when right information reaches them at the right time. So, alerting the medical professionals and public health authorities about any outbreak or any unexpected public health crisis is critical, as it can be a beginning of a pandemic or an epidemic. Also, providing correct information. It is very important to kind of provide the correct information to the public and the media, because to avoid panic. So in such situations, panic can happen, and it is very critical in biological disasters that people should be aware of the information, the correct information. Panic should not be created. So the public and media need to have that information, but it should be tackled very carefully. So the media is very useful for disseminating all these information to people and educating the community during a disaster. So uh, information flow is really important in such situations. There is also a lack of global collaboration during the disaster. So there is a lack of collaboration in terms of surveillance, reporting outbreaks, training, the workforce. The countries should have a robust reporting structure, and they should share this information with each other. They should not have a individual outlook, and really have a shared goal of controlling such biological disasters. So coming on to the public health responses, we have talked about all the issues, but talking about public health responses, I would just say that during any biological disaster, the most important response from a public health perspective is prevention. So, which we all know now, that you have to wear mask, maintain hand hygiene, maintain social distancing, quarantine. So other key elements apart from prevention is creating awareness, and awareness among the common people. So I believe that we cannot talk about public health without involving the public. So we really need to have a good, uh, you know, collaboration with the public, and including the leaders around. We need to have a good surveillance system for reporting the various outbreaks on time, and communicate all the information to the the correct information at right time to the correct people. So in the end, I think I would just say that we are living in a connected world, in a globalized economy, and biological disasters are an international issue. They are not something just related to one nation. It is an international issue, and now we have COVID as an example, and we can really work looking at that what are the impacts of such a pandemic, and how we can really collaborate and communicate with each other to have a better preparedness plan for any biological disaster in future. That's it from me. Thank you.
Thank you, ma'am. Thank you for the very insightful presentation on international public health issues at a global. As per the schedule, we were supposed to have the question answer round, but due to time constraints and time management, we are unable to go through the question answer round like as per asking the participants. But I think most of the questions which participants have asked in the question answer chat box has been answered. If not, then we will definitely mail the participants can, I will share the email address of the concerned speaker, and whatever questions they have, they can further mail it to the speakers. So finally, we have come to the end of the webinar. Since Sergeant Admiral V.K. Singh is still with us, I request if sir could give the closing remarks for the webinar session. Over to you, sir.
Sir, also may I request all the panelists to switch on their cameras and we can just take a screenshot as a memory of this webinar?
Hello.
Sir,
Yeah.
Sergeant V.K. Singh, sir, am I audible?
Yes. Yes.
Yes, sir. So if you could kindly give the closing remarks for the webinar session.
Okay. Thank you very much, all panelists and the participants. We have to improve at our end. I was attending all through, and one of the thing is that we have to have better time management. Maybe we have less speaker or whatever we'll decide, because the second such webinar is also there in this month, and we would like to have more participants interaction and also remove their doubts. I request all the participants who have a question, please send it to us. We'll reply or we'll pass it on to the people to do that. I'm thankful to NIDM and also my team and also all the panelists and participants for being with us for this 2 hours session. Thank you very much.
Thank you, sir. Since we have come to the end of the webinar, I would like to address the board of thanks. Firstly, I would like to thank our Executive Director of NIDM, Major General Manoj Kumar Bindal, who has always guided us, motivated us, and always helped us to conduct various webinars on various subjects. I would also like to thank Sergeant R. Admiral V.K. Singh, Air Marshal Dr. Pawan Kapoor, Dr. Raman Chawla, and Nimisha Singh for their time and consideration. Thank you so much to all the speakers for very insightful, for very enlightening presentation. And last but not least, I would definitely like to thank our participants who have been so patient with us, and I would really like to thank them for their time and consideration. Just few instructions. The feedback link or the feedback form will be mailed to all those participants who have attended 90 minutes of this webinar or more. And once we get back the feedback form, then the e-certificate will be generated. On this note, I would like to end the webinar.